Hello, can everyone hear me, please?
Yes, we can.
Yes, we can.
Oh, okay.
Can hear you.
All right, thank you. All right. So once again, good morning, everyone. Good morning, Prof. Good morning, everyone, and good morning, the nurses too. My name is Lumide Obia. So I'm the Leadership and Development Coordinator for HFN. So today we'll be having the third edition of our nurses training, which we do every month. So today our lecturer is the founder of HFN, the Health for Nigeria, and that is Professor Abimbola Akintade. So before we go straight into the lecture, I would like to say, to read a brief about Professor Akintade. So many of us know him, even the nurses too. So probably like just for us to have a detail about him. So Professor Akintade is the founder of Health for Nigeria. So he had his elementary education and secondary education in Nigeria, and then proceeded to the United States of America for tertiary education. He bagged an associate degree in nursing at Prince George College, Community College, Maryland, USA. And he also bagged a Bachelor of Science in Nursing at the University of Maryland, Baltimore. Masters of Science in Nursing with special focus on acute care nursing and clinical nursing specialty at the University of Maryland, Baltimore. A Masters of Science in Healthcare Administration at the University of Maryland Global Campus. A Master of Business Administration and International Business at the University of Maryland Global Campus. And a PhD Science at the University of Maryland, Baltimore. Working experience in academics. Currently, Professor Akintade is an associate professor and associate dean, master's program at the University of Maryland School of Nursing, Baltimore. Prior to this position, he served as faculty coordinator and specialty director in various units of the university, that's the University of Maryland, Baltimore, one of which is the Doctor of Nursing Practice, DNP program. Professor Akintade is also an active clinical nurse in the surgical intensive care unit and post-anesthesia care unit. And currently, Professor Bim Akintade is the Commissioner for Health at the Maryland Healthcare Commission, Maryland, USA. So, ladies and gentlemen, if we were to be in a physical meeting, I would have requested that we welcome this great scholar, an achiever, and a big enigma with a standing ovation. So, however, dear nurses and HFN staff, please welcome with me Professor Dennis Abimbola Akintade as he delivers this great topic. Thank you so much. Welcome.
Round of applause.
Welcome, sir.
Yeah, glad to have you.
So thank you, everyone, and thank you, Olumide. You know, that's an interesting intro, and what you read doesn't really, you know, sort of show my trajectory and my path and how I got here, or how even HFN started. You know, so. But you know, it's a wonderful opportunity, and I don't get to meet with the nurses often, but I should say to you guys that, man, I'm really, really excited about the work we're doing. I really appreciate you and your efforts. You know, Health for Nigeria was a vision. Most people who are in the United States, I mean, I've been here since 1996. You know, so if you do the math, that's almost 30 years. You know, in another 4 years, I would have been here for 30 years, which means I've lived in the US longer than I've lived in Nigeria, you know, so, but I've just never forgotten home. So for a lot of you, either during your interview or when we met, I shared my brief story, you know, about how HFN started, you know, I grew up in Nigeria, like most of you. I was born in Lagos. I tell people I was born in Nigeria, they don't believe me, but it's true. So I grew up in Lagos. I went to primary school first. In 1004 primary school, we moved to Antony Village. I went to school in Ilukbeju. After that, I went to St. John's College in Lagos in Pangrove, and then from there I went to Federal Government College Idoani. So I have a grounded Nigerian foundation. I came to the United States when I was 19, and shortly after my mother passed away. And my mother was someone who had hypertension, really bad hypertension forever. And I remember going to pharmacies to buy her medications when I was young, probably before I was 10 years old. I would always go to the pharmacy to buy her medication, and I just always wondered why, and obviously at that point I was really young. And hers was bad. She used to have nosebleeds, really, really bad. So I've seen how bad hypertension can impact people. In the year 2000, so if I came here in 96, 4 years after I got to the United States, she passed away. She had a heart attack, and that had a significant impact on me. As Olumide mentioned, I started out my career as a nurse. So like you guys, I worked as a nurse. I transitioned into sort of business and leadership. I got a PhD in cardiovascular health sciences. I'm a nurse practitioner here, which is an advanced practice clinician, and my focus has been cardiovascular health. And, it took me a long time to think about it, but when I finally made the connection, the reason why I'm interested in cardiac health is probably because of my mom, right? So I came to Nigeria in 2016, believe it or not, hoping to stay in Nigeria, to relocate back to Nigeria to identify opportunities for me and my family, because in my heart, true and true, I'm a Nigerian, and man, it was a very interesting experience. And one of the things I learned is our education system is lacking significantly. And in most developing nations that have issues with educational systems, healthcare systems are also lacking. So I firsthand experienced a lack of healthcare. And so when I came back to the States, that was a challenge to me. I thought to myself that, we have to do something. And that's how we came up with Health for Nigeria. So it's really exciting for me today to present to you. I do lots of presentations and lectures, but, for Health for Nigeria, I've always liked other people to come in. So we'll sort of get an eclectic perspective, different perspectives from different people. But when Olumide asked me to do this, so based on that history I just gave you, so, in terms of cardiovascular health, in addition to it being my specialty, that's what I got my doctorate degree in, but it's also an area that I've practiced clinically for over 20 years, so this is my area of specialty. Also, originally, the agreement was to give you a presentation that included cardiovascular health and also, I think, stroke and hypercholesteremia, and it just seemed like a big mix. So I've separated it. So today I'm only going to talk about hypertension, which means I'll get the opportunity to come back and I'll talk about strokes, cerebrovascular accidents, and then I'll come back and talk about hypercholesteremia. So that way we can sort of explore each one in their entirety, probably over 3 sessions. So hopefully that's something you're excited about. That's definitely something I'm excited about. So it's not only nice to work with you, but I also think this is a great opportunity for you guys to continue to expand your breadth of knowledge, so are there any questions or any comments before I start with the presentation? And also, this is not a lecture. You're not in school. We're colleagues. So if you have questions, comments, if you have an example you want to introduce, a similar situation you've experienced, please unmute yourself and speak. For those that I work with in the leadership sector, people like Folashade and Ruth and Olumide, we run a shared governance approach here at HFN. unfortunately, obviously, I haven't done a lot of work with you guys, but I'm very relaxed though, and I truly welcome engagement. So don't think you are in class and some teacher is talking to you. I'm not your teacher. But this is just an opportunity to share information, and the best way to share this type of information is when both groups learn something about each other. So I don't want to talk the whole time. Like, I'm hoping you guys will contribute also. Is that fair?
Yes, it's okay.
Yes, sir.
Okay. And you guys, the only guy among you, Luro, is like, he's really, really gapping the rest of you. So I want the women, HFN nurses, to give Luro a hard time. I think he won Nurse of the Year last year. So we want to give him some competition this year. So I'm going to share my screen now. Let me see. Can you guys see my screen? Can you see my screen?
Yes,
Yes,
sir.
sir. I see your screen.
Yes,
What exactly can you see?
we can see your screen.
Hypertension with silent.
Hypertension,
Okay.
silent killer.
Wonderful.
No.
Okay, good. 1 second, let me move this out of the way. All right, so today, okay, so you can see the cover slide, hypertension, the silent killer, right?
Yes, sir.
Okay. This is a lecture presentation I've actually given a few times, and I like this one for us today because it's not very scientific. I also teach nurses, I teach doctors this information and lots of other types of information. But this one, when I first put it together, I put it together for my church, which is interesting. So just like you guys that do community engagement, I do the same too. So there's a Biazo event in our church every year around March. I haven't done it in a while, obviously, because things have gotten busy. But every year I used to go to the church service and I would give this presentation and I would do blood pressure screenings. I'll take a blood pressure cuff and do the same and just report back, to each person, especially if their blood pressure reading is out of the normal range. So hopefully you guys see that the work that we're doing is relatively similar. Hypertension is called the silent killer because unlike many other healthcare conditions, hypertension does not present any physical symptoms until, for many people, it sort of impacts their mortality. Many people have died based on hypertension, but so the topic of our presentation today is hypertension, a silent killer. Like I said, I'll make this into a series, but I thought if we started adding hypertension to strokes, it may become a little more confusing. So the objectives for today's presentation, I'll talk more about hypertension. Many of you know about high blood pressure already, but I mean, this is an opportunity just to give you a little more information so that when you educate, a lot of our students in the nursery school program probably don't have this, but the individuals that you might interact with, like the teachers, the staff, principal, or during our community engagement, I think that's where this information will come in very handy. We'll talk about types of hypertension. We'll talk about some signs and symptoms, risk factors. We'll talk about complications of hypertension, how to reduce hypertension, and some additional support and resources. Okay. So for every presentation, I like to start with sort of the magnitude, like why is this an issue at all? So I mentioned earlier, I've lived in America longer than I've lived in Nigeria, but I probably speak Yoruba better than most of you here. I speak Ondo and I speak Pidgin probably better than all of you. So I don't want you to look at me like some American person. truly and truly, I'm Nigerian, but this is an opportunity to sort of create some comparisons. So approximately 1 in 3 Americans have high blood pressure. That's about 33.3% of Americans, 1 in 3. If you look at Nigerians, 1 in 2 Nigerians have high blood pressure. You know, that's about 50%. One of the reasons why I think it's higher in Nigeria compared to most other countries is that we don't put a significant emphasis on healthcare in Nigeria. So most Nigerians have never even gotten their blood pressure checked. Falashade does a fantastic job of giving us feedback from a lot of the work you've done. And she tells us, you know, especially for some of the people that you do blood pressure screenings on, that tell you that that's the first time they've ever checked their blood pressure. You know, so about 7.1 million deaths per year may be caused by hypertension. And we say maybe because even though hypertension might be the primary cause, there are some additional secondary issues that may superimpose that. We'll talk about that as we go along, but obviously some you can think of would be heart attacks, strokes, kidney failure. So only 77.6% of people in the country are aware of their condition. So only probably about 1 in 3 people know that they have hypertension. So the other, percentage are not aware, which is unfortunate. So what is hypertension? If someone in the community asks you, if you say, oh, you have high blood pressure, and they say, what does that mean? It's very important for you to have a very elementary way of explaining it to them so they understand. So hypertension occurs when the pressure in the arteries become high, causing the heart to work harder than normal to pump the blood throughout the body. So we understand the role of the heart, right? We have 4 chambers, 2 atria, 2 ventricles. They pump blood, out of the heart into the rest of the body. When we say hypertension occurs when the pressure in the arteries become high, if the pressure the heart has to pump against is high, it means the heart itself as a pump has to pump harder. When the heart works harder, that increases blood pressure. Okay, so then it makes you wonder, exactly why would pressures in the artery become high, requiring the heart to actually work harder? We'll cover that. So the pressure in the arteries when the heart beats and when the heart is at rest, that's what gives us our systolic and diastolic. I know a lot of this information should be elementary for you nurses, but at the same time, my hope is that this presentation sort of gives you like the opportunity to see this in an elementary way. So when you communicate it, you can communicate it more effectively. So the pressure in the arteries when the heart beats and when it's at rest. So the systolic pressure is the pressure of the heart when, through systole, that's when the heart actually contracts. That's the top number. The diastolic blood pressure is the pressure of the heart when the heart is at rest. So before I go to the next slide, what is the normal blood pressure? Anyone can unmute and share. So trivia question, what's the normal blood pressure and what's the normal heart rate for an adult?
Hello,
Okay.
sir.
Yes.
Good afternoon, sir.
Good afternoon.
Yes, so the normal blood pressure, is 120, but it's having a range, 120/80, but within the range of 90 to 60, range to 139/100.
Okay, that's good, and so the normal heart rate for an adult is 60 to 100. And anything below 60 is considered bradycardia, and above 100 is considered tachycardia. And in terms of blood pressure, textbooks will say 120/80. How many of you have ever seen 120/80? In my entire career, I've probably seen someone's blood pressure on a blood pressure monitor as 120/80, maybe twice. It's usually like 121/83, like so there's a range. But usually for essential hypertension, any systolic greater than 140 needs to be evaluated. So we'll say about 120 to 139. That's a fantastic response. And for the diastolic, about 80 to 90. Anything above a diastolic of 90 also needs to be evaluated. Okay. And when I say needs to be evaluated, you say that I didn't say they need to be on medication, because different things can cause hypertension. Hypertension can also be temporary, it could be transient, but it could also be permanent. Okay. All right. So how do you diagnose hypertension? And most of you do this, and I just want to make sure, in addition to the fact that we do it, we're doing it right. So based on the average of 2+ seated blood pressure measurements at your provider's office. So you don't take someone who has been running around, screaming, yelling, fighting, and then you take their blood pressure. What will happen if you do it at that time?
It
The
will be
blood
high.
pressure will be high.
It'll be high, because if you remember, blood pressure and heart rate is part of our sympathetic nervous system, fight or flight response. So if you what people did for me in Nigeria, where you are driving, an Okada jumps in front of you, they almost hit you, or someone hits your car, and you start yelling and screaming. That's a sympathetic nervous response, right? That's your fight or flight. At that point, your heart rate is probably 120 to 130, and your blood pressure systolically is probably 150, over 100. It doesn't mean that's your resting blood pressure. That's your blood pressure at that time. So if you're going to take a blood pressure of anyone, they should come in, they should sit down for probably about 5 to 10 minutes. I know sometimes we don't have time, so this may not be very realistic, but if you have the opportunity, they need to sit down and their feet need to be flat against the ground for 5 to 10 minutes. And you don't only take one blood pressure and say you have hypertension. If their blood pressure is high, you should probably take it again just to make sure. You should be in a quiet environment. Can you sit in the garage where cars are passing, everybody is pressing their horn, people are screaming, shouting, and you take someone's blood pressure and you expect it to be normal? No, I mean, for a lot of people, it wouldn't be, so if you're going to take someone's pressure, just make sure they are seated. A lot of the pictures we've seen for your community engagement, we've actually seen that. So you guys are doing a fantastic job. I know it's hard to control the fact that it should be done in a quiet environment. You also can't control the clothes people wear, but if people wear tight clothing, it may impact their blood pressure. And they should be seated with their feet flat on the ground for 5 to 10 minutes. Okay, so I'm going to talk about 2 types of hypertension. So primary hypertension is also called essential hypertension, and it's the most common type of hypertension. In most cases, the cause is not known, and most people with this type of hypertension, they have no symptoms. These are the people that walk around with high blood pressure, and they go about their day, they have no symptoms, they've never treated it, they've never even checked it. So, and for a lot of these people, they actually really don't even know why, so guess someone in this program today that has essential high blood pressure. Me. That was one of the things I got from my mom, because as I told you that story, hypertension is hereditary. And when it's hereditary like that, I believe in God, and I believe in religion and Christianity are 2 different things. I'm a Christian, but the way we do our religion has gone out of control. It doesn't matter how many blood of Jesus you call. It doesn't matter how much holy water you drink. My blood pressure is not going to change because it's hereditary. I got it from my mom. There's nothing can change it except medication. So I'm going to be on blood pressure medication for the rest of my life. I've been on it now for about 15 years. These are some of the things that you need to be telling people when you talk about it. This is my career. This is my field. Like I've learned about this now for about 20 years. And in everything I've learned, there's no religion about how to treat it, So that's just something you should be aware of. That's why I'm also very passionate about this. So when I wake up, the first thing I do is I take my medication. And after I take it, then I can go about my day and scream and shout and live a normal life. But I know that my blood pressure is under control. And then secondary hypertension is when high blood pressure is a result of other medical problems or medication. So sometimes if a person has kidney or liver disease, or they're taking one type of medication, that medication may, as a side effect or as a result, increase their blood pressure, okay? If you have any questions or any concerns, or you want to make any comments or add something, please feel free to just unmute and speak, okay? So American Heart Association is a internationally accepted sort of baseline or standard for how we evaluate many cardiac issues, and hypertension is actually one of them. So they've provided also a sort of a classification that we can go by. Can everybody please mute their devices? Sorry, I'm hearing some feedback. If you are not on mute, please mute. So according to the American Heart Association, normal blood pressure is a systolic of less than 120 over a diastolic of less than 80. So pre-hypertension is characterized by a systolic of 120 to 139 over a diastolic of 80 to 89. So this was what we talked about earlier, and this would probably be the range that you would like to see people: 120 to 139 systolic over 80 to 89 diastolic. So hypertension stage 1 is 140 to 159 over 90 to 99. When I was first diagnosed with hypertension, I would see my blood pressure in like the 140s over 90 something. Anyone who has seen me knows I'm in very good physical shape. Like, I started exercising and lifting weights and eating right. And when I did that, it came down, but then eventually it went back up again. When it went back up, I was probably in the best physical shape of my life. I had done all the exercise. I was eating right. And that was when I knew that, diet and exercise alone wouldn't work. I think the highest my blood pressure got to was about 160. And that's when I decided, okay, I need to start taking medications. So hypertension stage 2 is when your systolic is greater than 160 and the diastolic is greater than 100. So the percentage of adults with hypertension, so this is also something you should sort of keep in mind, that gives you a reference about how you sort of perceive people with hypertension. Is it normal? Is it not normal? Is it expected? Is it not expected? So from age 20 to 34, that's very young people, right? About 11.1%. A lot of these people either have other chronic ailments or, like me, hereditary, right? Age 35 to 44, more people. So men, 25.1%, women, 19%. My mom has 6 children, and so far, 4 of us on our hypertension or blood pressure medication. We're just waiting for the other 2. So when they get a little older, we know they are going to join us, because that's genetics. So 45 to 54, 37% and 35%, 55 to 64, 54%. So if you look at this, can anyone tell me the trend they can identify with this table?
It increases with age.
Absolutely. So it increases with age. How about comparison with men and women?
Yeah, it's more in men than in women.
Okay, good. So hypertension increases with age, and it's more prevalent in men than women. So, sorry, there's a helicopter flying past. From an anatomical perspective, one of the things that you should also understand, if you remember, the definition of hypertension is an increase in arteries that requires the heart to pump harder to overcome that increase in pressure in the arteries. The older we get also, our arteries become less compliant. So even without any other issues, no other healthcare condition, even if it's not hereditary. What's interesting is that age alone is a factor, is a risk factor for hypertension. The older we get, the more likely we are to develop hypertension. So if you see an older person with hypertension, they say, nobody in my family has it. You can tell them that, well, that's okay. This is also age itself is a risk factor, okay, for hypertension. So the percentage of adults with hypertension by ethnicity, well, this doesn't really sort of show Nigerians, because in Nigeria, it will be, we have one ethnic group, we're all Black. So it will be 100%. But if you're looking at the world as a whole, the race of ethnic groups in terms of percentages, 43% of African American or Black people have hypertension. That's for men, and 45% of women. Mexicans, 27%. White people, 33.9%. What I want you to take away from this slide, in addition to age being a risk factor, male versus female being a risk factor, is the fact that we're Black. Just by our ethnic group, we are more prone to hypertension than other ethnic groups. Okay, so that's something to also keep in mind and also to take away. So what are some signs and symptoms of hypertension? Even though hypertension, the signs and the symptoms of hypertension don't happen like in one day. It usually takes a while, many years of high blood pressure that has now had an impact on all the different systems in the body. So imagine if, let me give you an example. How many of you have been to the beach? Any beach? How many of you have been to the beach? Do you people not go out?
I've been to the beach before, sir. Thank you.
Now, so if you go to the beach, you see waves, right? Now, Laura, you're in the riverine area. That whole place is a beach now.
Sure.
Now, Bar Beach, Badagry, what other beaches are in Lagos now?
There's a beach in my local government.
See, I'm not surprised. I went to see the I went to see Obat once, Lauro.
Okay.
And when I went to his place, they told me that if we kept driving for another two miles, we would run into the ocean.
Yes.
Yeah, so that's interesting. But so just envision a beach with waves, right? Big waves, lots of pressure. Imagine if you should build a fence like right at the edge of the beach. The first day, the fence is going to be fine. Maybe the first week, even maybe the first month. But if you think about the beach with that pressure consistently hitting the fence over and over and over and over again, what's going to happen with the fence?
So it fall.
It will fall. So if we should think about heartbeat or heart rates, that's the number of time our heart beats per minute. So anyone that has hypertension, think about the fact that 160 over 100 is happening 70 times a minute, 100 times a minute, whatever their heart rate is. So their heart is beating with high pressure every single time it beats. With that high pressure event, it's only a matter of time. For some people, it's years, for some people, it's months, but they're going to start to demonstrate symptoms. So some of the symptoms include dizziness. That's if their blood pressure is so high, now they have like some neuro impacts from it. blurred vision, the arteries and arterioles in our eyes are very small. If you increase the amount of pressure that is hitting it over and over again, you're going to damage those arteries. If you do, it's going to impact their vision. Nausea, headaches. Headaches are probably the most common, headaches and blurry vision are probably the most common symptoms of hypertension. If someone tells you, man, I have headaches all the time. Man, I always have. The first thing you should tell them is to check their blood pressure. 9 out of 10 times that person is hypertensive and they've never been diagnosed. Drowsiness, nosebleeds. My mother had nosebleeds. I actually saw that myself. Shortness of breath. What are some other symptoms you guys have seen of hypertension in your practice?
Sleeplessness.
Huh? You guys, I mean, is this
Fatigue.
okay? Fatigue is a good one. Is this how you
That
treat
you're unable to
your?
see.
Is this how you treat the presenters that come here? You just sit down and let someone come and talk to you for an hour. No, now, like you need to make this more interactive. That way, you learn something. Someone knows that you are engaging. Don't just be quiet. Now, hypertension is something we see all the time. So, Falashade said fatigue. What else?
There's palpitations. Some people-
Thank you very much. So, heart palpitations too. So chest pain. See, and when patients start having palpitations and chest pain, I mean, you know that it's getting pretty bad. They need to see someone very quickly. So, in terms of risk factors, we actually divide those into two. We call them either modifiable risk factors or non-modifiable risk factors. Modifiable risk factors are things that you can change, you can modify. The non-modifiable ones, you can't, these are non-modifiable risk factors. You can't change your age. We're all going to get older, and the older we get, we will be predisposed to hypertension. Please don't say, God forbid, blood of Jesus. Please, please, please. It's ignorant. It's not educative. This is science. You can't argue with science. When I was in Nigeria, I went for a conference and I printed 100 flyers for hypertension. Because once again, this is an area in which I'm very passionate. And I stayed at the registration booth. So once people came in and they registered, I would give them the pamphlet, just so they are aware of high blood pressure. Only about 20 people collected it from me. And most people were like, God forbid, God forbid, I reject it. What are you trying to say? I reject that. God forbid, you are the one that will have high blood pressure. And just, it was sad to me because 50% of those people that came there are hypertensive. And we've gotten to a point where we rely so much on religion to solve our problems rather than use our common sense and listen to science. God is the same person that created us, that created doctors, pharmacists, and created science and medication. So, we should use all those things. So here, there's nothing about religion, okay? So age is non-modifiable. Race, like I said, Black people are more predisposed, and also genetics. If one or two of our parents have high blood pressure, there's a very good chance that we may also have it. And if we have it based on that, there's no modifying for that. That person would likely require medication to manage it. So some of the modifiable ones, which is actually, this is where you're teaching and educating. So the first one is clarification to let people know, but this is where there's an opportunity to actually teach. So for individuals that smoke, smoking actually hardens arteries. And if you remember the definition of hypertension, if the arteries are hardened, it would increase the pressure within the artery that makes the heart have to work harder to get the blood through. That causes high blood pressure. alcohol intake. Inactivity, if you are not active, if you are not moving, lots of those people become obese. They become, they increase their weight. So for individuals who are obese, now imagine for someone who weighs, let's say 100 kilograms, and someone that weighs 150 kilograms. Our hearts are about the same size for all of us. It's about the size of your fist. If you ball your fist like this, that's what your heart looks like. Which heart is going to work harder? The one that is pumping blood to 100 kilograms or 150 kilograms?
150 kilograms.
Yes, 150. So anytime you see someone that is overweight, not all the time. Okay, thank you. Anytime you see someone that's overweight, just think that their heart is working twice as hard to get blood all over their body, right? What is the use for blood in our body? Blood helps transfer oxygen, right? We need oxygen for cells to grow. So where are cells? Cells are everywhere in our body, so we need blood everywhere in our body. That's why if you cut your fingertip, your head, everywhere, blood is going to come out of there because you need oxygen for the cells everywhere in your body. The heart is the one that gets the blood everywhere. So for little children, the heart doesn't have to work as hard. Their surface area is relatively small. So we don't see hypertension in a lot of children. But when you think of adults, in addition to the arteries and issues with the arteries, so think of how much the heart has to work to stress. Nigeria itself is a scam. So everything in Nigeria is stressful. Another thing is too much salt. So does anyone know why salt increases our blood pressure? I'm looking for my science students now. Anyone? Okay, so salt, if you ingest a lot of salt, and in the food we cook in Nigeria, a lot of us use a lot of salt. Salt tends to retain fluid. So salt, which is sodium chloride, right? Sodium chloride actually retains fluid rather than making you, urinate a lot of fluid. The salt holds on to fluid. And so there's a sodium potassium balance in our body. When we are dehydrated, and we sweat, what does your sweat taste like? It tastes salty, right? If you are sweating, whenever you are dehydrated, that's how the body can tell how much fluid I should hold on to, how much fluid should I get rid of. If you don't ingest water much, do you pee much? You don't, because your body is going to hold on to the little bit of water it has. But the more water you drink, the more you pee. So salt and sodium, they actually help us sort of manage our fluid status in our body. So if you have too much salt on board, you're going to hold on to more fluid. If you hold on to more fluid, your heart is going to have more fluid it has to pump. Whoever that is, please mute your phone. So the more fluid you have on board, the more fluid. Can you please mute? Whoever is not muted, can you please mute? Or the admin, Olumide, can you mute whoever is not muted? Thank you. So salt actually helps control our fluid status. So that's actually one of the things you can tell individuals in Nigeria. Other conditions, that may be modifiable, people that have high cholesterol, I'll talk about that a different day. They need to control their cholesterol. People with diabetes, I can get someone to talk to us about diabetes a little more. Kidney disease or sleep apnea, okay? So once again, I've called hypertension the silent killer because until major side effects happen, a lot of people don't even know that they have hypertension. And many people actually die before they know. So people go to sleep, they die. We say it's their village people that is doing them. We say we don't know what happened, but they just had a heart attack because they've been walking around with blood pressure of 220 over 120 for the last 10 years. Not everything is village people or jazz. Sometimes it's just underlying disease that was never diagnosed. So what are some of the complications of hypertension? Hypertension can damage the brain, which is the most important risk factor for strokes. Remember, blood vessels in the brain. If the blood pressure is so high and one of those small blood vessels in the brain explode, and blood spills into the brain, when you hear or someone, that's a stroke actually. But for us, so we joke about it and we use it to abuse people. But scientifically, that's actually a stroke. A heart attack is a major risk factor for heart attack and the number one risk for heart failure. So I know very much about heart attack because my mother died of a heart attack. But also I worked in a cardiac intensive care unit for 10 years. And I treated patients that had heart attacks and had heart transplants. So I actually got a chance to see this firsthand, just how deadly hypertension is. It can damage the kidneys. It can cause kidneys to fail and leave people requiring dialysis or kidney transplants. In Nigeria, whenever you hear someone has kidney problem, automatically believe it's because of hypertension. Let me repeat that. In Nigeria, when you hear that someone has kidney problems, just automatically believe it's because of hypertension. Okay. And then the last thing, arteries. It's associated with stiffer arteries. It causes the heart and the kidneys to work harder. And it may actually affect the arteries in the eyes. I mentioned that earlier. So these are significant systems. Imagine if someone has a brain problem, heart attack, kidney failure, or have issues with their arteries. It will impact their quality of life. So how do you control blood pressure in the community when you're talking to people? That's the other thing. We don't ask important questions. Here in the US, we're very free. We'll ask you, do you smoke? Do you drink? You know, like, feel free to ask people because it will give you an opportunity to provide some teaching. So tell them to stop smoking. If you smell cigarette on them, say, you know, it smells like maybe you smoke. Or do you smoke? Even if they say yes or no, just say, you know, smoking actually contributes to hypertension. The nicotine present in tobacco products, it decreases oxygen to the heart. It increases blood pressure and heart rate. It increases blood clotting, you know, that may cause a pulmonary embolus or a deep vein thrombosis, or it may damage cells that line the coronary artery and other blood vessels. That alone can cause a stroke, even, you know, that may cause a heart attack, that may cause vision issues because some of those arteries are very small. Imagine having a tiny artery that provides blood to your eyes, and now you have clots, you know, or damage to the lining of that artery. That also can be a problem. So tell people to move. You know, people, whenever you say exercise to people in Nigeria, they think it's only rich people that can exercise. You know, we didn't say go and join gym because that's expensive. But walk around, get up, move, make physical activity part of your daily life. It strengthens the blood vessels. It helps control blood pressure. It decreases heart rate too. So 30 to 60 minutes a day to control blood pressure is helpful. It could just be walking. If you want to go to the store and the store is just down the street, don't take your car, you know, don't take a bike. Walk. I know security issues are a bit of a challenge, but if it's a secure place, you know, encourage people to actually walk and exercise a little bit. So people need to lose weight. And I know that's a challenge because we have to take social and community sort of impacts into account. In Nigeria, if women see a skinny guy, they say he doesn't have money, which is crazy. But, you know, weight now, just like we talked within the context of hypertension, is not healthy. People need to lose weight. Also, Nigerian men, they like their women huge. Unfortunately, that's not healthy. So we need to encourage people to lose weight. So even 10 pounds of weight loss can lower blood pressure. I mentioned earlier about obesity and how excess weight strains the heart and increases the work the heart has to do to get blood all throughout. We need to reduce our intake of fat. And in Nigeria, we eat, man. Even this 1 week I spent in Nigeria for the funeral of my father-in-law, I gained weight. Food everywhere. We need to slow down. Also, red meat. We like meat. Around 50 naira. About 50 naira, around 1,000. Even though I don't think there's about 50 naira anymore. So probably about 100 or about 200, around 2,000. That doesn't work. It doesn't work because the increase in meat, actually increases cholesterol. So you need to encourage people to watch what they eat. I know that's difficult. Even if all you tell them is to cut down on the salt they put in their food, that in of itself may make a big difference. So tell people that the food they eat will impact their survival. Avoid fat diets. People are always going on these different diets. you know Unfortunately, even if you do this diet that lowers your blood pressure, you are so hungry and so miserable that when you break away from that diet and you start eating again, you would actually increase the weight that you started from. So we need to eat plenty of grains. I know we do that in Nigeria. Fruits and vegetables. We eat vegetables a lot in Nigeria, but we don't eat a lot of fruits because fruits are expensive. But if we can encourage people to eat fruits, it will be helpful. Drink lots of water, avoid minerals, avoid, all these, sweet drinks. The more water we drink, the healthier we potentially can be. I talked earlier about limiting salt. That's a big one. Salt fills your blood vessels and body tissues with fluid. I mentioned earlier that salt helps retain water in our body. It puts a significant strain on the heart. It makes the heart work even harder. So according to the American Heart Association, 1,500 milligrams per day of salt is all we need. So we need to limit our salt intake. There's something called the DASH diet. Maybe if you guys have time later on, you can look at it. It gives you some recommendations that you can provide for people in terms of what they eat and how salt or sodium impacts blood pressure. Limit alcohol intake. I know most of us here are nurses. We probably don't drink as much, but drinking socially is probably not the worst thing in the world. Every now and then, but you can't go to work, come home, and then open a bottle of whiskey every night. It will impact your blood vessels. It would impact your liver. It will impact your kidney eventually. All those things affect blood pressure. So drinking in moderation is reasonable. Preferably wine. Wine is good for the heart. But when you drink beer and whiskey and scotch and rum and tequila and, all those things have their negative impacts. So it directly raises blood pressure, it damages vessels. So either decrease it to a reasonable amount. I drink from time to time socially, but not amukbara like we say in Nigeria. So either decrease or eliminate it. And as much as people will say, God forbid, I'm not going to use medication. We need to help people understand. When all else fails, if you've lost weight, if you've tried dieting, and now you have symptoms for hypertension, people need to be on medication, and we need to let them know it's not a life sentence. I wake up, I take my medication in the morning, take water. That's it. I don't have to think about it. I don't have to worry about it anymore. I check my blood pressure right now. The last time I checked it, my blood pressure was about 133/88. I can live with that. 133/88. That still puts me in that pre-essential window. But I can live with it. But whenever people say, oh, no, they don't want medication, I don't want their blood pressure is only going to continue to increase. Okay. So sometimes even doing all the right things, it will not lower your blood pressure to an acceptable level, especially if people are older or it's genetic. They have someone in their family that had it. So when that happens, though, you need to refer them to their medical provider, send them to a pharmacy. They need blood pressure medication. Okay. And blood, once again, look at me. Do I look like I have a life sentence? No. I mean, uh, sometimes people stigmatize it, but me, I know that if I want to live long, to continue to do good work and impact this world the way I want to impact it, I need to be healthy. One of the things I need to do to be healthy is to take my blood pressure medication. I mean, it's as simple as that. I also have two little children. I want to be around for them. So I believe in God. I go to church, I sing and dance in church, but I still take my medication. So they say heaven helps those who help themselves. So this is part of helping people understand that they have to help themselves. So always ask your doctor what medicine he or she is giving you and what it's for. So some people will just take any medication. We should be in control of our health. We need to empower people. Ask exactly what the medication is for. Pay attention to how this new medication makes you feel. Some medications for hypertension can make you feel bad. For some people, and you guys are healthcare professionals. Some men, if they take medications for high blood pressure, it may cause erectile dysfunction, which means they may not be able to get an erection to have sex. And men, if you ask them, do you want to be able to have sex or do you want to die? They will choose sex because, that's the way they're wired. So because of this, some men will just stop taking the medication. Unfortunately, they may get worsened symptoms. So that's also education we can give. Not all antihypertensive medications causes erectile dysfunction. Some of them do, yes. So patients should pay attention to how the new medications make them feel. If it makes one feel a way that they don't like, it can always be changed. Okay. Report any adverse or any side effects to your doctor or your health provider. Never stop taking blood pressure medication without the permission of your doctor or healthcare provider. Some people would say, I stopped taking the medication. Why? Because my pressure was normal. They are forgetting that it's the medication that is making their pressure normal. The moment you stop taking it, the pressure in those arteries haven't changed. It will go right back up and the pressure will go right back up. Unfortunately, there's no other way to say this, but individuals with hypertension that require medications, that's something those people would probably have to do for the rest of their lives. And there's nothing wrong with that. I'm a young man, at least that's how I feel. And I've been on blood pressure medication now for the last 15 years. Every day. I don't think I've even missed it. Maybe once or twice, but it has become part of my daily activities, become part of my personality, part of my behavior. Okay. So in summary, you may be at risk and need to check your blood pressure if you have either or both parents that are hypertensive. And these are ways you can teach other people, but I'm even also saying this to you people here today. If one or both of your parents are hypertensive, or if they were hypertensive, you may be at risk. If you are over age 30, if you're over age 30, here, raise your hand. Most of us are over age 30. Are you Black? All of us are Black. Are you overweight? Do you exercise? Do you not exercise? If you don't exercise, you're at risk. Do you drink alcohol or do you smoke? Do you have unexplained headaches, dizziness, or drowsiness? If you have any of those things that keeps happening 9 out of 10 times, that person may have undiagnosed hypertension. And are you under a lot of stress? So me, if I didn't have hypertension because of genetics, I will have it because of stress, because I am very stressed. I do a lot of different things, just like Olumide mentioned. In addition to this, I'm the commissioner for health for the state of Maryland. If you look over my right shoulder, that's my certificate from the governor of the state of Maryland, certifying me as a commissioner for health. In addition to that, I'm the founder of Health for Nigeria. I'm very involved in the organization. I'm the associate dean here for the master's program. I serve on several boards for many organizations. I'm very active in very many different things. I'm a father, I'm a husband, I'm a son, I'm a sibling. I have the responsibilities of family, so a lot of those things cause stress. Even those are reasons why an individual may be hypertensive. So if you look at any of these risk factors, if it impacts you, then you should be checking your blood pressure, okay? And even though I know it's not easy, but here in the US, we recommend that everybody have a blood pressure cuff at home. In Nigeria, for individuals who have hypertension, you should recommend to them also, if they can save small money, they should buy a blood pressure cuff so that if they have symptoms, they should be able to check themselves, okay? And so I just provided some very, very quick references for you, just in case you guys want to look up some more information regarding high blood pressure. And finally, if you have any questions, any concerns, if you want to follow up, if you heard something or you have something you want to share, you want to clarify, you can reach out to me directly. You can reach out to Olumide, Folashade, or Ruth. I typically make myself available, for anyone that needs to reach out to me. So that concludes my presentation. Let me start.
Wow. Thank you so much, sir. In fact, not just the nurses, even myself, I've been so blessed with this lecture today. And probably one way or the other, I will probably have to reach out to you, maybe to do some consultations too, because this is just like a live lecture, probably like talking about the things we feel and we experience even in our bodies. So, and I believe that others too are experiencing the same thing and are also feeling the same way I'm feeling. So thank you so very much, sir, for this wonderful lecture. So, and to everyone, nurses, staff, if you have any questions, please, the floor is open for you to ask questions, please. Thank you.
Thank you, Olumide.
Thank you so Thank you so much for the wonderful presentation, sir. Sorry, I have a question. There are some people that have high systolic and their diastolic is normal. Why some we have high diastolic and their systolic is normal? Why some we have both at the high side? And to me, I think if we are giving them one particular antihypertensive drug, for instance, someone that is having high diastolic and the systolic one is normal, wouldn't that affect the systolic that is normal as well and make it low?
So, okay, Palumi, that is a fantastic question, and that just means you're thinking even at the next level. Typically, whenever we think of hypertension, we think of both the systolic and diastolic being elevated at the same time. But at the same time, there's something called systolic dysfunction, and there's also something called diastolic dysfunction. And those two are parts of heart failure. So those are actually in a completely different category and they're treated differently. There are actually specific medications that are targeted towards either only your systolic or diastolic blood pressure to help regulate those. So those won't fall under our typical essential hypertension. Those usually are geared more towards heart failure. And some of the causes for that hypertension itself, some of the challenges include pressure in the arteries. In terms of systolic hypertension, now we're like talking about aortic stenosis, where it's only the systolic that has to work so hard to get pressure through the aorta. After that happens, there's nothing wrong with the diastolic. The diastolic can actually relax, okay, but it's a systolic that has an issue, or diastolic dysfunction, where the ventricles may be so muscular or so expanded from hypertension. Because if you think about it, the heart is a muscle. So if you look at me, I have some muscles, right? If I keep lifting weights and lifting weights and lifting weights and lifting weights and exerting a muscle, what's going to happen? It's going to be bigger. So if the heart is a muscle and the heart is pumping at a very, very rapid rate, or with very high pressure over time, some of those chambers are going to become smaller. So if the chamber can't fill during diastole, that could be diastolic dysfunction. But at that point, we're now talking about heart failure. So that's a completely different category. And maybe in future, I'm like happy to do a presentation on heart failure, because that's something I've done, at the college level too, or university level too. But that's a good question.
Thank you, sir.
You're welcome. You're welcome. Any other questions? Any comments?
Okay, please go on. Please go on, Laura.
Thank you very much for the presentation, sir. I just want to make 2 contributions and ask a question. My first contribution is that I like the fact that during the presentation, you were bringing in personal stories to just buttress what you're saying. For most of us, I think when we go out, we should endeavor to at least integrate our personal stories. For example, when I go out, I used to tell people that I think in 2015, my BP used to be around 120 to 130. And I found out like in the space of 5 years after, I started having something like 140, 150. It was even running high to as high as like 155. Then I later realized that my mom was also having issues with her BP. So I guess it was mostly hereditary, just like in her own case too. Yeah, she's been on medication and it's come down. And for some period too, I was on medication. For now, it's back to normal. And I also lost a colleague in nursing school back then. She died because of severe hypertension. I was running as high as 220. And so most of the time, it helps to just bring in our personal stories when we go out. And then the second contribution is when you put up the number concerning how age affects, and we were trying to contrast between male and female. I think one of the trends that is also there is that women's BP tend to experience a sharp rise. So I think we should also factor that in when we go out. Some people will be like, I've been checking my BP, Jerry, is not high. So those ones are also factors, because I think there's a theory that female hormone has a regulatory.
Yes.
Post-menopausal, there's a sharp rise, particularly among women. And then my question is just, because I've been asked once and I was able to explain a bit, but I just want to get a comprehensive answer on it. The comorbidity of hypertension is mostly diabetes, and that of diabetes is hypertension. I was reading somewhere that like 70% of people with hypertension have or end up with type 2 diabetes mellitus. So why is it that the two are they are brothers, sort of?
So see, this is the benefit of this type of forum, that we can share information, but the discussion really is where the learning happens. So thank you for your first comment, and it's not it's not easy to share your own story. I recognize that because many of us don't want to put ourselves out there. We don't want our information out there. We don't want people to judge us, or we don't want um, uh, we don't want to be stigmatized. I think with me, over the course of my life personally and my career professionally, I've recognized that everybody has a different type of style, and you have to identify what style works for you. So I'm a teacher, I'm a professor. I stand in front of students and I teach. And I recognize that when I teach just from the book, even though students get it, but it doesn't provide a rich experience. So I bring in my clinical experiences and I tell them a lot of the mistakes I made. I also tell them some of the things I did very well. And it is so engaging because it brings real life applications to the topic, so you guys can practice that, if you're teaching someone about something that you have personal experience with, or something that you've witnessed, someone else have an experience with it. Um, it's almost like using the case study method to like teach, so never miss out on an opportunity to pull in an example, because it only cements the point. The second thing you said, you're actually like absolutely right, because looking at the trend from age 55 to 64, so 45 to 50, 45 to 54, the percentage of women is 35.2. Once they get from that 55 to 64, they jump from 35 to 53. The next thing, they jump to 69. After that, they actually pass the men to 75. And Laura, you're absolutely right. That's postmenopausal. And usually for for the women here, that's part of why women are so complicated. Hormones. There are like so many different hormones they deal with. And even some of those hormones are growth hormones, so hormone is actually part of it, estrogen, progesterone, and how those things change during menopause, so that's a fantastic point. And even just some of the symptoms that come along with menopause is stressful to the point where that might also predispose them. But your last question, which is another good one in terms of hypertension and diabetes, it's like depression and anxiety. Those ones too, they are cousins. They go everywhere together. Someone that has depression likely has anxiety. Someone who is anxious also probably has depression. So insulin-dependent diabetes, which is diabetes mellitus type 1, is usually where there's damage to the pancreas, either autoimmune, or it may happen as maybe trauma or an accident. And when you damage the Isles of Langerhans, I think they call it, in the pancreas, that's where glucose, our insulin is produced. That sort of counterbalances glucose, that helps us maintain our blood sugar. So that's type 1. Type 2 diabetes. In type 2 diabetes, we actually produce insulin, but we don't produce enough insulin that can help neutralize glucose, and that increases blood sugar. So if you're looking at hypertension and looking at diabetes, a couple of things. I already mentioned the damage and the impact of high blood pressure on arteries. So the arteries that lead to the pancreas, just like the arteries that lead to the eyes, to the brain, to the kidneys, if those arteries are damaged, the ability of the pancreas to create insulin is going to be diminished. So that could also cause diabetes type 2. Another thing that we talked about is increasing weight and obesity. So most people who are overweight, not most, but a lot of people who are overweight have diabetes type 2 for the same reason. So if you think about it, if the pancreas has to work first, if the heart has to work so hard to compensate for a lot of weight, 250 kg, the heart is not going to increase in size. It's small. So I mentioned earlier that the heart is a muscle. So if it's beating so hard, rather than the heart itself become bigger like this, it's the chambers inside that become thicker. The walls of the chamber become thicker. So the space inside the chamber to accumulate fluid, blood that gets pumped to the body is reduced. So now the heart has to work even harder to get more fluid out to meet our oxygen demands. So if you think about an obese person, the heart has to work harder already anyway. And in addition to that, think about the damage that increase in pressure is going to have on the arteries that lead to the pancreas. So even though those two things can exist in isolation, just thinking from a pathophysiological perspective, there's definitely a correlation. And also not only diabetes, even though diabetes is more common, kidney disease. Most people, and I don't know what the percentage is, I'm sure I can look it up, but a high percentage of individuals with renal failure have diabetes. Have hypertension, because once again, the blood pressure significantly impacts the renal arteries. If those renal arteries become damaged, man, that person is in trouble. And most times, if you can't get to the hypertension quick enough to treat it, it may lead to permanent damage. So does that help sort of explain why diabetes type 2 and hypertension seem to coexist most often?
Yes.
Okay, so okay, Pelumi typed a question: why is someone with hypertension at the younger age not curable? And so, once again, it depends on what the cause of the hypertension is. For most young adults aged less than 20, if I were to give you an educated guess of why they would be hypertensive, it would be one, as it would be secondary to some chronic disease they already have. So they have another clinical condition going on, and now hypertension is superimposed. It could be that, or the hereditary hypertension, maybe from either their mom, dad, or both, is manifesting early in their life. And another thing is, it could be idiopathic. Maybe we just don't know the reason. It could be autoimmune. We just don't know the reason, But I mean, I've seen even young children with heart failure or young children with hypertension, and they have healthy parents. It could be a reaction to something. It could be a sequela from an illness, So it could be different reasons, but the two that I can think of is probably a complication from a chronic disease process, or an early manifestation of a hereditary process, from either of their parents or both.
All right, so thank you so much for the lecture. Thank you so much for the responses to our questions as well. So before we'll probably close, I think I should throw this one in. In a situation where, okay, I think there's a question too, but let me ask mine first. All right. In a situation where maybe someone checks the blood pressure and maybe it's around that 110, 80 or something, then probably at another point it's around 120, then at another point back to 110 plus, then maybe at a point, sometimes like, let me check again, it's around like 130 or like 140, then maybe going back home, rest and all, then at another point to check again, maybe the next day or after, like checking again, it's back to like 110, stuff like that. So what can we say that signals, sir?
So Olumide, that's a fantastic question, and the answer is very simple. We have many nurses on the call today. So the question or the answer to or for you is, when is the best time to check your blood pressure? For someone like that who is trending their blood pressure, trying to identify if they do have high blood pressure or not, you should check your blood pressure the first thing in the morning. Ever before you've exerted yourself, you've gotten up, you've gone up and down the steps, you've looked at your bills, you've paid for something, you've shouted at some Okada rider, so many things throughout the day may potentially elevate your blood pressure. But for that person who it seems like their blood pressure is moving all around, when you wake up first thing in the morning, you sit on the edge of your bed and you put your feet down on the floor. You wait for a couple of minutes and you check your blood pressure. That blood pressure should be probably your most accurate. Okay.
Thank you, sir.
Falashade, I know you have your hand up, but Okekpelumi is challenging me today and I like it. So since excess salt intake increases the sodium level in the body and thereby increases blood pressure, can we encourage someone with hypotension to be taking high salt? That's a fantastic question. And I can see you are like thinking and putting these pieces together. Unfortunately, that would not be a good recommendation because it would be difficult to be able to appropriately identify how much salt would correlate to a specific increase in blood pressure. So we can't say if you add 10 milligrams of salt, it would increase your systolic blood pressure by 10 millimeters of mercury. Like there isn't a direct correlation. And salt just in of itself, even if a person is not hypertensive, it's not necessarily good for your health. Even if it doesn't manifest as high blood pressure, it also creates some electrolyte imbalances, that may not be healthy or helpful. So I wouldn't recommend that for someone who is hypotensive to take higher doses of salt. What's interesting is hypotension is actually also not a bad thing, especially if your body is in tune with it. But for an individual who is hypotensive and they are symptomatic, maybe they have right. So Laura talked about hypernatremia, which is kind of where I was going with the electrolyte imbalance, but I didn't want to get too scientific. But yes, if you take too much salt, that may lead to hypernatremia, which may cause even other issues. It may actually shrink the cells of the body, which is actually interesting. But yeah, as long as that individual is not symptomatic, hypotension is actually not necessarily a bad thing. But if they are, in that case, rather than encouraging an increase in salt intake, we can encourage an increase in fluid intake, which I think is like what you are trying to sort of allude to. If you increase salt, you increase fluid, just increase the fluid without the salt. And that would help. Falashade, you have your hand up.
Yes, sir. Thank you so much for the wonderful presentation, sir. During the presentation, you spoke about exercise and its importance in reducing hypertension, and you even shared your personal experience concerning that. But I know most of us would have had this experience before. I've had it before, that you'll be speaking to people about the prevention and even lifestyle modifications to help them manage the high blood pressure. And one of it is exercise. Sorry, I have sore throat.
Mm-hmm.
So, but most of the time, they will complain to you that the work they are doing is stressful. Like some of them, they go to the farm from morning to evening, and you are still talking to them to exercise. So they will tell you even the work they are doing, bricklaying, carpentry, truck driving, all those things, it's more than exercising their body already. So I don't know if you can tell us more about it. Though I used to tell them that engaging in stressful activities is different from exercise.
Thank you.
But I don't know if you can help us, if you can enlighten us more on how to
to handle situations like that, so that these people will understand the difference between exercise and stressful activities like the type of job or the work they are doing.
So that is a very important point that you are raising. Many people actually just assume that because I'm a bricklayer, I'm a farmer, that means I exercise. You're right. It means they engage in very stressful and strenuous activity for a long period of time. But exercise is intentional. There are also different types of exercise. So I'm sure you've heard cardio in terms of, oh, I'm going to do cardio today. What does cardio mean? Cardiovascular. We've like nicknamed a type of exercise cardio after heart healthy sort of goals and outcomes. So the type of exercise you should be telling them to do includes walking, jogging. That's different from farming. So if they walk 5 miles to the farm, then they've already exercised. That's fine. If they jog, already because they have to run from place to place, that's fine already. But I think it's just important to to help them differentiate those two things. Even though some strenuous activity also gives the heart some cardiovascular exercise, but what I typically, tell people to do, I tell people to jog, but I also recognize that the older you get, there are other musculoskeletal issues, that don't allow older people to jog. They can just walk, wear comfortable clothing, comfortable shoes, and go for a long walk. But you can't walk one day a month and say you are exercising. That walk should be consistent so that the body can actually benefit from it. So at least three times a week would be, probably enough of that type of cardiovascular exercise. So in my opinion, that's the difference. Strenuous manual labor and exercise are two different things. And so I have a question from INE here that says, thank you for the presentation. My question is, in a case where a person is diagnosed with hypertension and then is on medication, but during the medication, the BP was like 100/80, getting low from like 140/100. Can the person stop the medication, since a person with high BP should be on medication? And if the doctor was the one that told the client to stop the medication, then maybe after a long period of time, the BP is back. So in my opinion here, I think the person was hypertensive. They started a medication regimen and their blood pressure became low. Rather than stopping the medication, I would decrease the dose. What you don't want is start, stop, start, stop. Whenever people take medications, what you are looking for is called a steady state. You want a certain amount of that medication to be in your body so that at every point in time, it is having the desired effect. So thinking about pharmacokinetics or pharmacodynamics, you don't want this. You take it today, you skip it for 1 week, you take it today, you skip it for 1 week, you take it today, you skip it. If you take it every day, you are going to maintain a steady state, a steady concentration of that medication in your system. So my recommendation in that case, say the medication they were on was 10 milligrams, I would decrease it to 5 milligrams and let the person continue to take it and see what happens. But also, I wouldn't stop taking a medication without speaking with the person that recommended it or the person that prescribed it. So even though I know Adewonyibo Latife has a hand up, but there's another question here by Yabo Salami. In pregnancy-induced hypertension, how do we group this, since it's not inclusive in the common risk factors? Though if it's not well managed, it could be malignant. So this is also a very, very important question. It's actually inclusive in what we described. So one of my slides said types of hypertension. Primary was people with no symptoms, which would be hereditary, age. And secondary is when blood pressure is a result of other medical problems or condition. Pregnancy is a medical condition. So so that would be secondary hypertension. And you're right, for most people after the delivery, pregnancy induced hypertension usually decreases and it goes away. But unfortunately, pregnancy induced hypertension or pregnancy induced diabetes remains even after the baby is born. So how do you group this? We group it as secondary hypertension because it's caused by another pre-existing condition. In this case, I know we don't like to think of pregnancy as a medical condition, but it is. All right, so Boluatifa, you have your hand up.
Good afternoon, sir. Good afternoon.
Good afternoon.
Thank you so much for the presentation. Okay, I just want to be sure there's this time I was doing the patient's BP, and he said in the morning when he checked with the aneroid that he got a lower figure, I think of around maybe 120 thereabouts. Then by the time he presented at the clinic, I think it was like around that 140. I prefer to use the manual SFIG, the mercury SFIG. I prefer to use it. So I would like to ask if someone is using the aneroid, because what I've heard, I've not confirmed, is that for you to get an accurate figure, maybe you do it 3 times, then you take the average. That's for the aneroid. But I prefer to use the SFIG. But for someone that wants to check personally at home and you don't have anybody around to help you to do it, and the person says that he wants to regularly check the BP, so how do you advise that person? Because normally I tell them that, okay, do it 3 times and take the average. That will let you have the idea of what it can be. So I just want to be sure about that, the difference between the SFIG and the aneroid SFIG. Thank you, sir.
Oh, all right, you're welcome. So I'm going to ask you a question, and you have 3 seconds to answer. What is 111 times 150? 1, 2, 3. You can't answer that. You know why? Because
why, sir?
You probably need to grab a piece of paper and do some multiplication. But if I ask you to use your calculator to do 111 times 150, how quickly can you get that done? That is a very elementary example to give you between the difference between a manual SFIG and a digital one. We cannot compete with the technology. I agree that if it's not properly calibrated, there could be a systematic error in the automatic SFIG. Yes. But if they are well calibrated and they work the way they should, with a manual SFIG, I'll be the first person to tell you I've never been able to get an accurate blood pressure. That's just me personally. Maybe it's my hearing, maybe it's timing. I've never been able to use it. And I've worked in a trauma and cardiac surgery ICU now for my whole career, over 20 years. So I'm very used to just looking on the monitor to get a blood pressure, and everything is digital now. So if you, for our clinics, we provide both manual and electronic ones, because we recognize that with the manual ones, if the battery runs out, we don't want you guys to be left without equipment to work with. But the manual SFIG should be a backup, in my opinion. Earlier I said we are colleagues, so we can agree to disagree, because I'm sure there are people that use manual SFIGs and they are excellent at it. They are very accurate with it. But me personally, and according to the literature, the electronic ones are more accurate. And when I say accuracy, is the ability to repeat it several times and get the same response. So for this person who wants to check their blood pressure at home, technically the electronic SFIGs are one user operated, so they should be able to measure it on their own, or if not, they can get a second person to help them do it. But my recommendation to that person would be to check their blood pressure first thing in the morning. They sit up in bed, they sit on the edge of the bed, they put their feet on the floor for about 5 minutes, and they should check their blood pressure. And even what you said earlier, if you check your patient's blood pressure in the clinic one day and it's 140/105, you don't immediately diagnose them with hypertension and start treating. Usually you tell them to come back a second time. And this time, when they come in, you let them sit in a quiet room by themselves for about 5 minutes, loosen their sleeve, put their feet on the floor, relax for a good period of time, and then take the blood pressure. At that point, I mean, you can do the average of 2. So hopefully that helps.
Okay, sorry, sir.
All right, Victoria Ige says, thank you so much. A staff of my school showed up with a reading of 160/100. She was counseled on compliance with medication, but from her reaction, it shows she isn't ready to take it, but believes she will be fine. So in such situations, what else can be done? At that point, it's just education. You just tell her that with a blood pressure of 160/100, even though I know our people are very spiritual, if you talk like this, they'll think you are trying to talk bad about them, but someone with a blood pressure of 160/100, if it's not treated for an extended period of time, they're going to end up with a stroke. You just need to let the person know that, listen, I can't make you treat it though, but the normal systolic is 120 and the normal diastolic is 80. At this point, what is the classification of so that is actually stage 2 hypertension. You just let the person know that if they don't treat it, they're going to end up with kidney failure, they're going to end up with diabetes, they're going to end up with eye problems, and potentially a stroke or a heart attack. Also, someone says, sir, can we say lying down while taking blood pressure isn't right? Yes, that is not right, because you have to evaluate sort of atmospheric pressure, right? Like, I mean, how does the heart perform? And based on all the standardizations we use for blood pressure, the only way that you can accept a laying down blood pressure is if someone like the American Heart Association says, these are the parameters for a seated blood pressure. These are the parameters for lying down. But all the parameters we have by which we evaluate or we diagnose or predict or we provide medications for hypertension is based on someone sitting down. So if you should lie down and take your blood pressure, it will give you an absolutely different reading, because now the heart is in a completely different position. The pressure or the needs, the flow of blood from the heart is altered. So the pressure needs are also going to be altered. So that blood pressure is going to be different. And unfortunately, we can't use that along with our usual classification. So if someone says they lay down to take their blood pressure, you need to let them know that it will give them an erroneous blood pressure reading. So what is the correlation between, and this is okay, what is the correlation between hypertension and threatening life event for someone without hypertension before, e.g. loss of loved ones? So if I get your question properly, you're asking what's the difference between hypertension and a situational hypertension? Maybe that situation is someone lost a loved one and now they're hypertensive. It depends on how high the blood pressure is. I was talking to one of my colleagues yesterday. Her 21-year-old son committed suicide. So she said they're heartbroken, they're devastated, they don't know what they're going to do, and someone like that, if you check her blood pressure right now, it's probably high. If it's high enough to the point where she has symptoms, she may need to be on medication. This is one of the few times I would say someone may need medication for a temporary period of time, a short period of time, because she's going through grief, and her sympathetic and parasympathetic nervous system is going to react to this situation. Is there a chance that after that life event, like the loss of a loved one, that the pressure would come down? Most of the time, yes. But just like my interaction with Iyabo Salami, sometimes, just like pregnancy-induced hypertension, it may not come down. It may not come down after, and that person may require it, but most of the time, it will come down. So if this person is grieving through the death or for the death of a loved one, and the blood pressure is 140/90, would I treat it? Probably not. I'll just tell the person to take it easy. If the blood pressure is 160/100, will I treat it? Yes, I probably would, understanding that it may be for a short period of time. If the blood pressure is 220/120, that person is going to have a stroke, whether they are grieving or not. So hypertensive urgency and hypertensive emergency, you are going to treat it, even though you are taking into account what the baseline is, but you have to treat that as an emergency. Okay, and the goal in that position is to bring down the blood pressure. If it's someone who has had chronic hypertension and their brain, everything is used to a blood pressure of 250, you don't want to bring it down too quickly, because if you do, they'll have a stroke. But if it's someone who is grieving, you may want to bring that blood pressure down. So Iyabo Salami is asking, here in Nigeria, the automatic blood pressure monitors are not usually accurate at times due to some technical issues. So I suggest we compare with the aneroid just to be sure in diagnosing hypertension in a patient for the first time. So Iyabo, that is a fantastic recommendation. I completely agree with you. You have to remember, my own barometer for decision making is a little different from yours, because my natural instinct is to think of what we do here. But I know there are some ABA-made blood pressure automated ones in Nigeria that may not be accurate. So you're right. If you use the automated one and it's very high, you should correlate that with a manual SPIG just to make sure. I think that's reasonable. Fortunately, here in the US, most of the over-the-counter things, our Food and Drug Administration, the FDA, is very, very, it's like NAFDAC in Nigeria. The FDA here, man, they don't play. Anything they accredit works. Like that, you can go to sleep, rest assured. Like NAFDAC in Nigeria, where they will say something was made in January 2023. And it expires in January 2026. We are not even in 2023 yet, and that goes through NAFDAC. So I agree that if someone's pressure is high before they're diagnosed with something as significant as hypertension, yes, I would do the correlation. Really, Laurel, you're saying the automated one gives you wide-ranging numbers. Do you guys want me to buy them from here and send them to you?
Oh. If you can do that, sir. Most of the one here, even if you check it right now, check it again, the range will just be too wide, like 30 milligram difference, some 50 at times.
All right, Falashade, let's do two things. For the blood pressure, the automated SPIG, and I think the blood glucose one is probably fine, but for the blood pressure SPIG, let's take that off our list for Medford, and I will just buy it in bulk and send it, and that way we can replace the ones the nurses have with. We have some brands here that are very reputable, like Orion and some other ones. I have two at home for myself, and they are very consistent. If you use it, you try it again, it works.
Okay, sir. All right, sir.
All right. Kayode Esther, we are hearing your voice today. Oh, that's wonderful. Can antihypertensive drug prevent pregnancy? So to the best of my knowledge, the answer is no. Antihypertensive drugs, the goal of those medications are not to prevent pregnancy. And a lot of them, whenever they do pharmaceutical research, they make sure it's safe for pregnant mothers. So typically antihypertensive drugs do not prevent pregnancy, and a lot of them don't affect or impact pregnancy.
All right. Thank you so very much, sir. Thank you, everyone. It's been a fantastic and an interactive session. So, is there someone raising? Okay, yeah, putting it down. So once again, I want to say a big thank you to you, sir, for making our time out of your busy schedule. We know you're a very busy man, and we want to thank you so very much for firstly giving us this platform as the HFN, and also like making our time to also be a part of this nurses lecture to share your experience and your wealth of knowledge as well. So, and to our nurses, thank you so much for attending. Thank you for the good work, and also the coordinator. Thank you. Like, it's so obvious that you've been doing a great job with the nurses and all. And also from this part, from this angle, I'm also assuring you that by God's grace, we continue to have avenues to impact your knowledge the more. So thank you so much once again. Sir, I don't know if you have any parting words before we close the session today, sir.
No, Lumini, I just want to appreciate you and the fantastic work you are doing with not only the lecture series, but also these series for our nurses. So for the nurses also, don't worry. I had to take a break to get some other things done, but at some point our leadership and management program will be up and running, and you guys will have the opportunity to go through that so that you get some additional experience, leadership experience, so I don't want you to ever feel like you came to HFN and you left without something tangible. In addition to the clinical practice and just sort of the way our organization is structured, it would be nice for you to leave here, wherever you go, with some leadership experience. So thank you, Olumide, for the work you are doing. Folashade, thank you for being a fantastic leader and an advocate for the nurses. So if you guys don't know, Folashade is always fighting with me, advocating for you guys, so that's wonderful. Ruth, our operations coordinator extraordinaire, thank you very much for the work you're doing and for just being our anchor point, for all the different programs we have. And most importantly, to the people who are really, really doing the work of Health for Nigeria, our nurses, you guys have really made us proud, man. You've done such a fantastic job, the type of impact we were hoping to have, on not only the students, the staff, or the community, but just, even though the work we're doing is not something that has impacted the whole country, but the little we've done, I mean, I know we've changed many lives. We've prevented death. We've increased access to healthcare. We've improved quality of life, and we've responded to life-threatening emergencies in ways that, I mean, people's lives may have been changed negatively forever. So thank you so much, everyone, for the excellent work you do, and I look forward to spending some more time with you, over time. Hopefully we can come up with some times where I can just, even if we just have conversations and just talk about some of the challenges, some of the opportunities, exchange ideas, but thank you very much for the work you're doing. So once again, thanks everyone. I'm really happy, about the progress and the strides Health for Nigeria is making.
All right, thank you, sir. Thank you, everyone, and do have a great day, sir. And to the rest of us here in Nigeria, do enjoy the rest of your day. Bye for now.